Dr. Allan, let's talk a little bit about CD20. We heard a little bit about the three-arm randomized trial with ibrutinib plus rituximab or ibrutinib monotherapy versus BR. What are your thoughts around the utility of a CD20 antibody in the setting of first BTK inhibitor-based therapy, and particularly maybe a comparison of rituximab versus obinutuzumab as a partner choice?
Yeah, absolutely. So I think it's a great question, and it's something I don't know if we've answered fully yet. So to give some context to some of the viewers and physicians and or patients maybe watching, there's been a head-to-head study, it's called CLL11 from the German CLL study group, where they looked at obinutuzumab chlorambucil versus rituximab chlorambucil versus chlorambucil. It's a three-arm study, ultimately in older patients with comorbidities. What that study showed is that obinutuzumab seems to be the superior anti-CD20 antibody in terms of its efficacy, with improved response rates as well as progression-free survival and trend and a very modest, even potential overall survival benefit in these older, very sick patient populations. So obinutuzumab seems to be, it's a glycoengineered antibody, has enhanced ADCC as a mechanism of cell kill. And in my own anecdotal experience, it does appear to be an extraordinarily effective agent. And so that brings some context to what, what I'll lead into. So this study you mentioned, the Alliance study, which we looked at ibrutinib rituximab versus BR, there was no difference with adding rituximab to ibrutinib in terms of response rates, MRD rates, or progression-free survival. Literally, the lines were overlapping. And so that led many of us, and frankly, I still use monotherapy BTK inhibitors, and I'm not using anti-CD20. But that brings us into the fact of the matter, we've never seen obinutuzumab with ibrutinib versus ibrutinib alone. There is a study, Illuminate, which looked at ibrutinib obinutuzumab versus chlorambucil obinutuzumab. What we see are a little bit higher response rates at the first data cut, and what we've seen is that that's a better agent. And we don't have single agent data, and as we know, as monotherapy, you continue to deepen your response. So is it that patients may just get to a deeper response faster, and will that mean anything later on, 3 to 4 years later, or will everyone kind of just plateau and get there? You just got to that response faster with the better anti-CD20. So it remains unknown because we don't have that monotherapy arm. With that said, the Elevate-TN study, which was acalabrutinib obinutuzumab versus acala versus chlorambucil obinutuzumab, does have that monotherapy arm. What we do see is that the response rates are better or deeper, and trend to be, CR rates are a little bit higher, MRD rates are a little bit higher in the acala obinutuzumab arm than what we saw with rituximab-based agent. And what that study showed, as Dr. Burks mentioned, did show this potential superior progression-free survival. Now, it's very modest, an absolute difference of only about 6%. And so the study wasn't powered to be able to show that statistically, and so you can't really state that's a true difference. And frankly speaking, follow these patients out another 3 to 4 years, those lines may come together because the anti-CD20 is only 6 months of the overall treatment. And so I think it does bring up this question of maybe if you combine the better anti-CD20 agent with a BTK inhibitor, you may be able to impact a longer-term outcome. I'm a little skeptical of that. There are some issues with it. Obinutuzumab does have infusion reactions, does require IV administration. There are cytopenias that we have to deal with that can be very problematic for some of our patients. They're getting growth factor. They're getting very thrombocytopenic. They're on a drug that may enhance bleeding. You may see more bruising. All these kinds of things that you have to be worried about in kind of the real world practice of some of these patients who aren't quite eligible for potential clinical trials that we're treating in the real world. And so I think there's potential benefit for it, but honestly, in a drug, and we've kind of mentioned this a little bit about, a drug like a BTK inhibitor that you're using for years, I find it hard to believe that 6 months of a treatment with an anti-CD20 up front will significantly impact that longer term outcome. And so I think that remains to be seen with obinutuzumab. And I think as the Elevate-TN study continues to mature, maybe that slight difference in MRD rate will matter in terms of a longer term treatment. If there's a significant number of patients that did achieve MRD, we do know those patients typically do better. And if you're remaining on a treatment and you're in MRD and you remain in MRD, that line may start to differentiate based on those patients who were able to achieve it. So I think there's a lot of interesting aspects about that specific anti-CD20. It is a superior drug. I do think it is the anti-CD20 we should use when we're using an agent for CLL. This does not hold across other histologies, though. We have not seen obinutuzumab improve outcomes against rituximab in DLBCL, or in, and we have actually seen it in follicular lymphoma have some impact there as well. So there are some properties about it that are special, that are unique. It does have some other issues. I do think there is some value to it, but when I'm using a BTK inhibitor, I am still typically using it as monotherapy for a lot of these reasons: the infusion reactions, the cytopenias, the fact of the matter that a long-term outcome may not actually be impacted by doing this when I'm using a drug that's continuous. May change a little bit if we talk about a BCL2 inhibitor in fixed duration, but I know we'll be getting to that a little bit later. But that's my thoughts on that situation in terms of anti-CD20 and BTK.
Dr. Burke, are you using CD20 with your BTK inhibitor-based therapy in the frontline setting?
No, I agree 100% with everything Dr. Allan just said. I echo his skepticism that adding the anti-CD20 is going to really impact long-term outcomes. I mean, and even if there is a small difference in PFS that holds, or maybe becomes a little bit significant over time. I mean, I certainly question whether that will translate to, OS benefit. And, the equation is complicated, right? It's not just all about PFS. It's about overall survival. It's about toxicities. It's about cost. We say what treatment is better, and the definition of better has to do with a lot more than PFS. So the short answer to your question is no, I'm not adding anti-CD20 to my BTK inhibitors right now as initial therapy.